Evening. My name is Robert Martin. I'm based at the Alliance for Health Policy and Systems Research, a WHO-hosted partnership. We have a fantastic lineup and session planned today. Thank you for joining us. We're planning on having a very interactive session, so please do enter your questions on the right where it says question and answer. We'd really like to encourage you to make questions and comments throughout the presentations and throughout the discussion today. We're going to be discussing conflicts of interest which hinder improvements in quality of private healthcare in low and middle income countries. Given the huge role of the private sector in delivering health in many countries, I don't think I need to explain why these questions and challenges of potential conflict of interest are pervasive and profound. So before we get started, I'd like to give a quick overview of our session and introduce our speakers. As you can see in the next slide, we're going to start with a quick discussion on what is a conflict of interest. We're then going to move on to insights from countries, Pakistan, Cambodia, India, and Uganda. And then we're going to open up for a discussion. We're going to start with some scene setting from Michelle Khan. She's a social epidemiologist with extensive expertise in quantitative and qualitative health policy and systems research. Her current work focuses on developing strategies to improve the quality of healthcare and governance in the health sector. She's an associate professor at LSHTM and the Aga Khan University in Pakistan and is an associate fellow at the Chatham House Global Health Program. We'll then move to Meenakshi Gautam, who's a research fellow in the Department of Global Health and Development, also at LSHTM, where she works on AMR, stewardship, and the private health sector in LMICs. We'll then move on to Eleanor Hutchinson, who's a social anthropologist who works on anti-corruption in the medicines retail sector from a health systems perspective. She's been at LSHTM since 2008 and was at the United Nations Institute for Social Development before that. We'll then have a presentation from Michelle. After that, after the country presentations, we'll move to have responses from two discussants. First, we'll hear from Freddie Kitutu, who's a lecturer and researcher on health systems pharmacy at Makerere University in Kampala, Uganda. His research interests include retail health markets and LMICs, AMR, stewardship, and pharmaceutical systems. We'll then hear from Priya Balasubramaniam, who's a senior public health scientist affiliated with the Public Health Foundation of India. She's also executive director of the Center for Sustainable Health Innovations in Singapore. Her interests are in health technology and innovation, UHC, and mixed health systems. At this point, I'd like to hand it over to Michelle to get us started with some further scene setting around conflict of interest. Michelle, over to you.
Great, thank you for that wonderful introduction and welcome everyone. So as Robert mentioned, this session is focusing on conflict of interest, which some of us have spent a lot of time focusing on, and others it might be a new area. So I hope we'll have some interesting discussions. When we are talking about conflict of interest in this session, we're particularly focusing on situations in which the professional judgment of a policymaker or a healthcare provider could be influenced by the potential for personal gain. And this becomes problematic when their decision-making is way, either in the case of, say, a healthcare provider, what is optimal for a patient, or in the case of a policymaker, what would be an optimal decision for public health improvements. So when their personal gain or the conflict that creates in their mind shifts away from optimal decision-making. Underlying this issue of conflict of interest is always the potential to use entrusted power for private gain. So both healthcare professionals and policymakers hold a position of power, and often, for example, in the case of healthcare providers, there's information asymmetry, which means that they have power and often trust, which can then be used. An important aspect of conflict of interest, which I find particularly interesting, is how subtle it is. Conflict of interest occurs even when no actions are taken. So when we compare it to what we traditionally describe as corruption, such as taking of bribes or overbilling for procurement, that is quite a clear action. Whereas conflict of interest is something that happens even inside someone's minds when their decision-making is shifted away from what's best in their professional capacity. And this makes it difficult to catch and difficult to regulate. In our session, we are really focusing on how conflicts of interests can end up moving us away from what the technically correct public health policies that we'd like to see implemented, or that policymakers state publicly are their priorities, and what happens in terms of policymaker actions. So how these conflicts can be a cause of differences between stated intentions and policies and actions. And we're particularly focusing on the quality of healthcare in the private sector. There's three themes that we are going to be covering as drivers of these conflicts of interest. Number one is the dual role and the relationships that policy actors have, and how their dual roles in terms of being regulators and potentially having links with industry means that they are conflicted. So that's theme number one. The second theme that we'll cover is when formal healthcare providers, doctors, pharmacists, publicly state that they support regulations against informal practices, but actually covertly support them, and how this creates a conflict which drives a wedge between technically correct policy and policymakers' actions. And finally, another force that can limit the implementation or planning of policies that are technically correct is when policymakers themselves are aware that the health system weaknesses are enabling the private sector to become powerful, and they're aware that implementing some of the policies that are stated is not feasible in their healthcare system. Underlying all of this in the grey box on the screen is that political forces, hidden relationships, and competing interests. And I hope that's going to lead us into a very interesting discussion. Back to you, Robert.
Thank you very much, Michelle, for getting us started and reminding us of the importance of the subtle nature of conflict of interest. Really important. Also grounding us with these three themes to focus on the dual roles of policymakers, the informal actions of formal providers, and how health sector stewardship plays a role in determining and defining conflicts of interest in health sector service provision. So thank you, Michelle. Moving on now, we're going to start with the country presentations. We're going to first hear from Meenakshi. Meenakshi, over to you.
Thank you. Thanks, Rob. I'll start by sharing my screen. There. I think you should be able to see it now. Okay, so hello, everyone. I see that we have 4 of 5 attendees. That's great. Thank you so much for joining, and look forward to having a nice discussion with you. So I am a health systems and policy researcher at LSHTM, and I will be talking about my findings from the work that I've been doing on antibiotic practices and stewardship issues in India. And I'm going to begin by tabling. Just give me a second. Sorry, I think I should I switch off my camera, or should I just keep it on? Just keep it on, I suppose. Okay, sorry about that. So I'm going to start by tabling the whole issue of informalities of practices, because this is a key outcome of conflicts of interest. I've been looking at the provision and use of antibiotics in human as well as veterinary health in community settings in India. We began with a focus on informal providers of human healthcare as well as informal paravets. And when I say informal, I mean that these are providers who do not have a formal medical or a veterinary qualification, but they are trained informally, either by doctors or veterinarians, or even by some other short-term courses which are not formally recognized. So we began with a focus on these providers, but we soon found that it was very problematic to limit the term informal to a group of people, because informalities were just cutting across different actors and across different aspects of the antibiotic system. So starting with this provision and use of antibiotics, it was not just the informal, but also the formal who were using antibiotics in a very non-standardized way. And you can see here that the excessive use of antibiotics in India, as some reviews show, is 55% more than the use by informal. Communities also resort to a lot of informal practices. Then you have the vets and paravets who also use human antibiotics in veterinary conditions, especially for small animals, because they're less costly, they are economically more suitable. So there is a whole lot of informality going on, and pharmaceuticals are really aggressively marketing and incentivizing antibiotics among informal providers in this scenario. The informal providers are being trained by both the pharmaceutical industry as well as private doctors. And you can see over here that there is a small group of paravets that we found in a remote part of the Sundarbans in India. They are being trained here by a pharmaceutical representative. Everyone is trying to expand their clientele in rural areas. Now here I want to highlight that these pharmaceutical reps are much maligned because they happen to be the visible face of the industry. So in many papers, you'll find that, medical representatives or pharmaceutical representatives need to be trained, they need to be restricted. But the reality is that they just reflect corporate strategies. The Indian pharmaceutical industry is one of the largest growing in the world. Almost half its turnover is from the domestic market. And this is projected to increase 9 to 12% in the coming 5 years, with much of this growth expected from increasing penetration of sales in rural areas as urban markets become saturated. We learned that many global companies also have rural health divisions because they can't survive without it. We also found that private doctors have very good relationships with informal providers. They are consulted by informal providers when they are in doubt, and their unspoken understandings of knowledge in return for referrals. But on the surface, the Indian Medical Association continues to oppose any proper integration of informal providers. So lots of links and relationships happen below the radar. There is also an informal pedagogical system in place for training primary care providers. So there are some NGOs and all that have programs for primary care providers, and they give these kind of certificates. And I'll just quickly read out these couple of quotes which emphasize what I'm saying, that informalities support expansion of private enterprise. They, that is the pharma companies, do not come to meet us only for the trainings. They also want their products to be sold in the market. They tell us to prescribe their products and give our feedback, etc., etc. This is, these quotes are from informal providers whom we've interviewed. Then another one about doctors, that the doctors said, if you see that BP is high, give necessary medicine, which a doctor can only give. But if we see a patient with nausea, high blood pressure, myocardial infarction, we are allowed to give all these drugs in order to save the patient's life. If the blood pressure is not becoming normal, then you must transfer the case to us. So this just shows how the informal are being advised and trained, and they are contributing to expansion of private healthcare, but all very informally. I also want to tell you a little bit about the regulatory scenario, and I want to focus on two types of regulations and show you how these in turn promote irregular practices. For example, the regulations that call for prescription only sales of antibiotics are first of all unmindful of the reality that a large majority of people living in LMICs do not have easy access to a formal prescriber. Moreover, such regulations are difficult to enforce. not just because of capacity issues in the regulatory departments, but also because of regulators' very real fears that strictly enforcing these will adversely affect health access and outcomes. So they are not just, these regulations are not able to prevent misuse, but at the same time, they are a barrier to practical solutions for antibiotic stewardship. People will say that, oh, we can't allow these people to use any antibiotics legally because the laws don't allow, but it's okay if they use illegally all the time. And of course, this kind of an ambiguous and loose situation opens the scope for a lot of irregular practices, including corruption. Another set of regulations are around medical education, especially around the creation of informalization. And for this, I have picked up a framework from Urban Studies, where Ananya Roy, a leading scholar, she's highlighted how the state's own planning apparatus can produce informalities. In India, the institutionalization of India's healthcare and medical education in the 1940s deinstitutionalized large numbers of providers who did not have a degree, a university degree in medicine, without creating an alternative legal, pedagogical, or service delivery architecture to meet the country's health needs. Medical regulations designed for the formal sector have continued to criminalize IPs, informal providers, but have neither succeeded in eliminating them, nor reducing them, nor in creating suitable human resources for the delivery of primary healthcare. And these are in a way also linked with the kind of global discourse that we have and what is promoted at the level of global governance, because the universal health coverage discourse has tracking indicators like measuring health worker density through physicians, surgeons, and psychiatrists. And this in turn could influence the kind of health workers that countries end up focusing on, and not necessarily those who really deliver primary health care to the masses. So my last slide is about the complexity of conflicts of interest, using this example of political leaders, many of whom are known to have a stake in private medical colleges in India, which in turn, the private medical colleges charge very exorbitant fees. And you can see the difference over here in the medical education fees between private colleges and the topmost government colleges. It's just the government colleges charge just, it's nothing compared to the private fees. And the private fees in turn also promotes a kind of culture of business orientation, where the graduates will definitely focus on getting returns on their investment. And it leads to a low quality of healthcare because there are a lot of unnecessary procedures and the quality of education is also not very great. How can this be lowered? One suggestion has been to cap the fee in private medical colleges for 50% of the seats. People have actually, I met a politician myself once. He said, we were trying to lobby for at least 60% seats being capped with low medical education fee. But he said that there was no way that they were going to do it. At the most, they would agree to 50% of seats being capped. But this too has not happened, because who is going to legislate or enforce this? It goes back to the politicians. So this is how the cycle goes on. So I'm going to stop there, and I'll just summarize by saying that what I've shown you are a number of irregular practices rooted in conflicts of interest, and these are sustained by the elite in the health, industrial, and political systems. Thank you very much.
Thank you indeed, Meenakshi. That was fantastic. You really enforced the kind of burgeoning bricolage of informality, the complexity of COIs, just permeating the health system in a very pervasive way. You also underscored how policies are promoting informality. So thank you very much for those insights. Next up, we're going to hear from Eleanor Hutchinson. Eleanor, over to you.
Thank you very much, Robert. Super. Let me share my screen first. Great. It's super to be joining everyone to discuss conflict of interest. I think it's probably worth stating at the beginning, and I'll use a slide to go through this, that I come to conflict of interest from an interest in the medicines retail sector, but also in particular from an interest in the sort of new approaches to anti-corruption that we're finding currently in health systems that I think are exciting and bring together a range of concerns that we have about private sector health providers. I think one of the things that's very interesting is that, you know, Meenakshi perhaps comes at this from a concern with AMR. I come at looking at private sector providers from a concern with anti-corruption, but we essentially get to the same place as we think through the problems that we have. So I'm going to talk to you then about research that I've been doing with colleagues in Uganda, including, I should declare, Freddie Katutu, who's also on the panel today. But this has been a sort of range of qualitative ethnographic approaches. We've been working in drug shops in different districts in Uganda for the last 4 years. And then prior to that, been doing some qualitative research. So it's long-term research in a particular health system. So let me just talk briefly about how it is that this work fits into, or how we can think about conflict of interest as part of a new approach to anti-corruption in health. So the new anti-corruption approaches start from a recognition that sort of good governance, transparency and accountability approaches to corruption and conflict of interest as well haven't yielded the results that we've hoped for. And the reason that they do this is because they ignore the context in which people live and provide care very often because of their reliance on blueprints for action. Everyone should do the same sorts of transparency and have the same sorts of transparency and accountability approaches across the world. They tend to create universal benchmarking processes that don't consider historical context. They also tend to seek a transformation of the whole sector, which can seem impossible when you have the sorts of challenges that I'll talk about and the sorts of challenges that Meenakshi and Michelle will also talk about. And they also fail to take account of the fact that sometimes corruption and informality arise as a form of problem solving, that you are in such a difficult situation, or that there simply isn't enough funding in public sector medicine, for example, that actually what you do is use private sector in a particular way, or you engage in different forms of corruption as a way of solving the immediate problems that you face as a health worker or as a policymaker working in the health system. We don't think that all forms of corruption are problem solving, but you need to take those problem solving elements of corruption into account. So new approaches to anti-corruption, and this is where my research on the private sector in Uganda is currently sort of focused, seek to take into account context, social relations and politics to enable pragmatic policies that offer feasible solutions to the most pernicious or problematic forms of corruption. So what we're looking at are the points at which we can really make a difference in the given context, recognizing that we can't always make the sorts of changes that we want to make because of the political context in which we're working. So politics is really important in this approach. And if you want to read more about it, we have papers published in BMJ Global Health and the International Journal of Health Policy and Management. So let's move on. This is the sort of new approach to anti-corruption in health. And really for the first time, we're trying to use it among private sector providers. So the case that I'm going to talk about today then relates to Ugandan drug shops. People, you'll see a photograph there. I'm sure they're actually quite familiar to people working in Uganda, but also we see similar shops like this in Tanzania and in Kenya, and people will recognize, you know, very simply put together shops with a range of commodities in them. So in Uganda, drug shops are the most, so when you go into a particular area, you always find many more drug shops than you will find pharmacies. So these are in many ways the most important sort of providers of primary healthcare through the private system. But Ugandan drug shops are only meant to sell over-the-counter medicines. They're not meant to sell antibiotics. And they have always been thought of as a temporary part of the health system. So they emerged during the time of civil war in Uganda when the health system essentially collapsed. And they emerged informally at first to provide employment for health workers selling medicines, but also access to medicines. And these are the two key areas that they've always sort of maintained this work for some health workers, but also other untrained people. But critically, they enable access to medicines. So in formal policy, drug shops are meant to be registered once and licensed. They're meant to pay a license fee annually, and they're meant to be owned and run by a nurse or a midwife. So that's how the formal policy sets them up. Informally, however, drug shops are incredibly important in terms of buffering the tensions that are created by a very poorly funded public health system and a very expensive formal private health system. So very often Uganda has been unfortunately sort of well renowned in the past for having very severe stockouts of essential medicines in the public health system. Ministry of Health officials that we've talked to have said that they consider that the government really only procures around 50% of the essential medicines necessary for the country. So the private sector, and drug shops in particular, are incredibly important in terms of distributing the medicines. So this is the sort of first point, that there's an informal national policy or informal national rule that is that people know that drug shops distribute essential medicines. So similar to the case that Meenakshi was talking to. But they also provide employment and they provide additional income for poorly paid public sector health workers. So nurses, lab technicians, clinical officers, and sometimes doctors have a drug shop or have several drug shops that they can provide and help them provide an additional income that supports them with their low pay. But also what we're finding in the health system that we think is changing at the moment is that we are finding more and more what we've called surplus health workers. So unemployed nurses, especially unemployed nurses and midwives who have been fully trained, often in private colleges, and are unable to get work in the public health system. Not because the public health system has enough nurses already, but because there isn't the capacity to take them in, there aren't the finances to take them in, there aren't the systems in place to take them in. So this is really the double role of these drug shops, and they provide essential medicines, they also provide employment. So this sort of the gap between the formal policy and the informal national policy then also is sort of added to by the informal practices that there are in drug shops. There are many unregistered, and those that are registered often at their annual license slip. There's little control on the numbers of shops. Competition is very fierce. They sell antibiotics and other medicines beyond their license, offer inpatient services, and sometimes employ untrained personnel to work in the shop with them. And occasionally, although not as much as we thought, we find medicines stolen from the public sector for sale in the private sector, but mostly we just find rumours about these things. So the gap between the formal and the informal policy, so the policy that's written down, but then and then the policy that the sort of informal rules that people work with, we think creates space for bribery, so that regulators will stay silent about rule breaking, especially around untrained personnel, but also to ignore the sales of antibiotics and to ignore the provision of inpatient services that we quite often find in drug shops in Uganda. This gap between the formal and informal policy also creates very crowded medicine markets. It means that this sort of lack of regulation means that drug shops pop up all the time. And some work that Freddie and I are doing at the moment shows really how saturated these markets are. Huge numbers of drug shops in particular areas that mean that it's very difficult to turn a profit, impossible to turn a profit within the formal rules of the game, but also that you get very high markups on essential medicines. And as you know, Freddie has often said to me, it means that these markets don't really work for anyone. It means that the drug shop vendors are constantly, that shops very often close because it's very difficult to make a profit. The people coming into the shops are spending an awful lot of money on the medicines relative to the amount that they were purchased for. But at the same time, you know, we're not the only people who've seen this. We're not the only people that know this. There has been, the scope to reform and decongest these markets is curtailed by Uganda's political settlement. So the national body that governs medicine markets is considered by the drug shop vendors to be governing these medicine markets for political rather than technical reasons, that they are excessively supporting market space for pharmacists. And so when there is ever any policy change that's expected to take place, the drug shop vendors are very often against it and come out en masse against that policy. So it creates very little room for dialogue, you know, to develop and change these markets in a way that actually may well support, you know, the better trained drug shop vendors who are in these markets. But also drug shops are seen as part of the president's constituents. So again, when policy is suggested that will curtail the space that drug shops can expect to have, what happens is that a lobby group that has been set up by drug shop vendors will go and heavily lobby the president. And drug shop vendors are often considered to be part of the rural population, very important constituents for Museveni, and that then the political wheels will go in motion to support drug shop vendors and to limit the space that there is to actually make changes in these markets. So that we can see that this is what, in Michelle's diagram, this is the political context in which, you know, people who are looking for technical solutions to these markets have to operate. But what we're thinking of doing, what we're doing now with our research, and this is my last slide, is to try and tease out who could and who would not support any intervention in the market, to try to reduce the number of drug shop vendors that are working in the market, and to try and make sure that the drug shops that are working have properly qualified people in them. We think that there are enough people in these markets now who are properly qualified. There are enough of these surplus health workers to mean that actually this market could become much more formalized. But we need to think about who benefits from this space between formal and informal policies, and then who doesn't benefit from that, and work with them to make changes in the market. So who doesn't benefit? Rent-seeking inspectors, untrained, unregistered drug shop vendors certainly would be against any reform. Health workers employed in the public sector who rely on untrained drug shop vendors to run their shops may well go against any attempt at reform to sort of clamp down or better regulate the market. But there are people who are interested in reforming the market and creating effective rules. So these, as we've said, these surplus health workers, these health workers who can't seem to get work anywhere else, are interested in making changes in the market so that they can more effectively earn a profit and have much more successful businesses. District level officials who have to manage markets and emergence of drug shops are also very keen to get a much better hold on these markets and stop the mushrooming of drug shops. The National Drug Advocacy Initiative, the drug shop lobby group, are trying to formalize the market in order to raise their profile. But we also need to see rules changing around what it is that drug shop vendors can sell, about who it is who's allowed to own drug shops, and about how we can create a system where there are fewer drug shops allowed in particular settings. Thank you very much. Sorry, I've run slightly over time. And I just want to say thank you very much to our partners involved in the research. Thank you.
Thank you indeed, Eleanor. That was a fascinating look into what's happening in Uganda, excuse me. You reminded us of the profoundly political nature, again, of these sorts of issues. You reminded us of new approaches to anti-corruption in health systems, the importance of context, the importance of social relations, the importance, again and again, of politics. Really, really interesting. Thank you. Again, I'd like to remind our participants and attendees, please ask your questions in the live Q&A. You can find that on the right of your screen. So please type in your questions there. I see one's just come up from George. Thank you, George. We will come back to that in the question and answer period, but hope and again encourage all of you to enter your questions. Now we're going to go to Michelle to hear about insights from Pakistan and Cambodia. Over to you, Michelle.
Thank you. I really enjoyed the presentations from Meenakshi and Eleanor. I hope the participants did as well. So as mentioned, I'm going to be sharing some insights from my research in Pakistan and Cambodia with my colleagues there, and some of which is still ongoing research. So really excited to share this with you. Some brief background which relates to the presentation. I'm going to be bringing insights from two countries, as mentioned. There's some similarities and some striking differences between them. to highlight the size of population difference, with Pakistan being about 200 million and Cambodia being about 15 million. But both have issues with a weak primary healthcare system, particularly in urban areas, and which results in reliance on private sector doctors and drug shops in both settings. In Pakistan, because of the size of the population, there is a large pharmaceutical market domestically, and there are over 700 companies, most of which are domestic Pakistani companies, that are competing for market share by using various incentive schemes. And this is quite an important driver of some of the aspects that I'm going to discuss. And in both countries, there are weaknesses in medical education and regulatory institutions, as we see in many of the contexts that we are studying. The particular aspect of Cambodia was the civil war that really took out a lot of the intellectuals, and including medical doctors and pharmacists. So against this backdrop, there's a lot of evidence of conflicts of interest, and I'm going to give you a couple of examples from Pakistan. Firstly, this idea of links between, say, pharmaceutical industry and doctors, which happens so soon during the training of doctors because of the presence of the industry at medical schools, just posters in the background, sponsoring of events, then leading to offers of benign gifts. So by this, I mean examples that have been provided to me in interviews include, oh, would you like a water cooler for your teaching hospital? It's so hot here, or this is just for the patients. So starting off with that to more personal gifts, resulting in very reliant on monetary and non-monetary contributions, such as access to continuing medical education from pharmaceutical companies or their sales representatives. So it becomes a really entrenched way of operating. And what we see happening because of this, evidence of some of the influence of this, is that in Pakistan, study has shown that almost 90% of medicines are prescribed by their brand names rather than by their generic names. And there have been multiple cases, only a few of which come into the news and legal action is taken. But there was one of a doctor who'd been referring patients just with that were coming with uncomplicated headaches or other minor illnesses for CT scans because they had a relationship with the owner of a CT scan clinic, who was also a doctor, and these two doctors had an arrangement whereby the referring doctor would get a share of the profit from any referrals there. And the pictures that I've got are from some news articles really showing that even now under COVID, there's a very strong reliance on support from the pharmaceutical industry, often which is benign, but it does lead to these links that are quite deep. So I'm going to, throughout my presentation, reflect on the three themes that were underlying this session. So the first is the dual roles and relationships of policy actors. And what came out very, very strongly is that policymakers and politicians end up being influenced by the groups that they are responsible for regulating. One of the reasons for this is because both in Pakistan and Cambodia, they hold dual roles, which means that policy actors in Pakistan, for example, who are regulators, also own domestic pharmaceutical companies. And so they have a conflict when deciding on policies that they think might result in a reduction of sales or profits from the companies that they own. It's pretty clear how that would happen. So they would either, what we found was shift or leave loopholes in the rules, or actively reduce the resources that are made available for implementing the regulation. In Cambodia, another example is that the Pharmacy Council is made up of pharmacists, which isn't unusual, but when they are also pharmacy owners, this creates a conflict when taking stronger actions against activities that lead to the profits of pharmacists. And what we saw is that both the main regulatory authority, so the Drug Regulatory Authority of Pakistan, and the DDF in the Department for Drug and Food in Cambodia, have both been, the interviewees reported regularly that there was systematic neglect in terms of resources that were made available to these agencies because of the links between the policymakers, politicians, and the owners of groups that would be regulated by them. In addition to direct dual ownership or dual roles, there was also these indirect links through familial or social ties. So an example that occurred both in Pakistan and Cambodia is that the small pharmaceutical companies or drug shops, there's very close connections to political elites or government officials. And what we saw is that as these drug shops or pharmaceutical companies become more profitable, this gives them even more money to be able to entertain politicians or policy actors, and there's this upward cycle in the influence which these companies can have on policy. So this quote from Cambodia, where you can see the frustration, is that an official was stating that they don't get support from policymakers when they're trying to enforce regulations. They try new interventions, but policymakers do not agree, so it cannot work. If we have support from the policymakers and corruption is cut down, it will go well. And moving on to the second theme, which Meenakshi and Eleanor also talked about, was these links often hidden between formal and informal providers, which means that formal providers such as doctors and pharmacists, when they're sitting across tables and having policy discussions, say that they will support actions to quote unquote crack down on informal practices. In reality, they actually actively support or benefit from informal practices. In Cambodia, we found that many of the informal drug sellers are only able to exist because they're relatives or friends of doctors, and this gives them access to knowledge, access to medicines, and legitimacy. Another very important finding was that both in Pakistan and Cambodia, this idea of trained doctors and pharmacists renting out their professional licenses such that clinics or pharmacies can operate without there being a licensed pharmacist or a doctor present, and this then allows the doctor to get an additional monthly income from running these sort of franchises almost. And this is actually quite a huge source of income for them, which means that they would not openly, while they might not openly oppose, they would have a conflict when seeing these sorts of informal shops being shut down, or rules that really enforce having a doctor or a pharmacist present in every clinic or pharmacy. The other thing that we see, the sort of third theme, is this idea that health systems' weaknesses themselves, which policymakers are cognizant of, drive the private sector to become powerful and also make it difficult or sometimes impossible to enforce the regulations. And when policymakers are aware of this, then this naturally influences how strongly they put support behind a policy, even if that's written down on paper. So one issue that a lot of us have discussed in many different fora is this issue, the tension between excess and access in terms of access to medicines. And this map that I have from showing pharmacy density in Phnom Penh in Cambodia really highlights that there's huge parts. You go slightly out of the capital city to peri-urban areas, and there are no licensed pharmacies there. So naturally, people that live in these areas do need medicines, and everybody knows that it is the unlicensed and informal drug shops that people rely on, and policymakers are aware that shutting these down, even though unlicensed shops aren't meant to operate, will create issues of access. And so there's political and ethical barriers, there will be huge dissatisfaction, understandably, between populations, within populations there. And this is something that also came up in Pakistan, as this quote highlights. So the respondent was saying, how will they being policymakers, follow it being rules when, let's say, a man comes in the middle of the night to a pharmacy and he's in need of antibiotics? How can I refuse this? There are some practical issues. So this is referring to informal pharmacies, and how can they not be providing medicines when people need them and there aren't alternatives available. Another example of these health systems dynamics is that it's really the norm that medicines are purchased without prescriptions, despite this being against the rules. And it's so entrenched that pharmacies or drug shops will say that they will have to shut down if they rely on patients with prescriptions coming in because it's so rare. And policymakers are aware that the cost of consultations are sometimes prohibitive, and patients do want to go directly to buy medicines, even if those are antibiotics that per the rules should only be accessed with a prescription. And the other really strong example that comes through in Pakistan is the reliance on the pharmaceutical industry for continuing medical education. So there isn't any system of continuing medical education that is provided throughout the country by any government agency. So doctors can essentially graduate and spend decades practicing without having any professional development or update training, unless they rely on the information that's provided from pharmaceutical company sales representatives or sponsored conferences. And this has become such a norm, and government authorities are aware of this, and they're aware that being strict on the relationships between the pharma industry and doctors will result in a vacuum of continuing medical education, which is really important. So the neglect of some of the investment in areas which policy actors are aware of means that they can't be very strong in enforcing some of the policies. So this is my last slide, summarizing my reflections on how the conflicts of interests end up influencing both policy design, where strong regulatory measures are not introduced, or policies that are introduced are done so with loopholes because policymakers don't actually want them to be influenced, to be implemented entirely. Also, when we do see policy on paper, a very strong theme was that insufficient resources are allocated to allow policies to be meaningfully implemented, and this is done on purpose by policy actors because they have conflicts, and by ignoring instances of failure to abide by regulations. Thanks for listening. I'd like to call out all my colleagues and collaborators who supported this research.
Okay, perfect. Thank you very much, Michelle, for those very rich and interesting findings from Pakistan and Cambodia. I think the examples you gave, I found very fascinating. I think we need to kind of update and beware of so-called benign gifts. Again, you gave us some very concrete examples around the dual competing roles of policymakers, how formal providers leverage informality, how weaknesses in stewardship enable or even empower the private sector to challenge the public sector's role in regulating and overseeing some of these potential conflicts. So thank you very much for your presentation. At this point, again, I'd like to encourage all of the participants, please add your comments and questions. We've now received a couple more, but please keep including those, keep entering those. We're going to come to you shortly. But first, we'd like to hear from our discussants. We have two. We're going to start with Freddie Katutu from Kampala, Uganda. Freddie, over to you.
Thank you very much, Robert. I'm very happy to join the panel from Entebbe, Uganda today. I commend the presenters, Meenakshi, Eleanor, and Michelle, for casting the lenses into the informalities in the three countries. I just want to draw the audience into the reality that in the reality of the health systems that exist in these countries, using Uganda as a case study, which is what has been described as a pluralistic health system, where we have both publicly funded services coexist with privately funded services. And before I continue to make my commentary, I like to ask to take a step back to note that health remains a fundamental human right, implying that whoever needs health, whoever is care seeking, usually they have no choice but to seek for it wherever it is. The second point is the fact that the pluralistic health system exists in these countries is also an adaptation due to, as Eleanor and the other presenters mentioned, weaknesses in the health system, inadequacies in resources. So a lot of what we describe, a lot of what manifests as corruption and conflict of interest, again, as Eleanor mentioned, is really problem solving, and problem solving to seek care, which as we know, we all need as a fundamental human right. The last point I will leave for the group that probably has been mentioned, but I like to emphasize is we need to look at the financing mechanisms in these health systems, and we need to appreciate that whereas we are casting the lens on drug shops and informal health providers, we need to look at them as part of the broader system within the pluralistic health system, the mixed health system, as some researchers have called it. That what happens in the private sector, what the drug shops adapt to, sometimes is affected by the kind of policies or healthcare provision that is happening in the public sector. With that in mind, we then need to examine the financing models in place and how those actually create conflict of interest, and how those manifest in the way in which, for instance, if a patient, a care seeker, needs to acquire a life-saving medicine and their funding is out of pocket, it implies that the health provider has to adapt in a way that they probably meet the health need, but also obtain the funding that is in the pocket, to put it literally, which implies that, again, such scenarios eventually lead to what we see as corruption and conflict of interest. But when you take a step back, it's really adaptation, trying to seek health, trying to seek life-saving commodities. I'll stop here and I listen to comments from my other colleagues. Thank you.
Super. No, thank you, Freddie. Really, really helpful comments. A good reality check from Kampala on the kind of interconnectedness, how these issues and these challenges are related to the complexity of health systems, how we need to view this and understand this from a systems perspective. I think, yeah, you've just again reminded us of how complex, how challenging this topic is. So thank you. Now we're going to go to Priya for her response, her comments. Priya, over to you.
Thanks, Robert. And I'd like to thank my colleagues, Michelle, Meenakshi, Eleanor, and Freddie for throwing some really interesting light on this very pertinent topic around conflicts of interest. And I think listening to the presentations as well as the content, I mean, I'd like to, lift off where Freddie said, it'll be interesting to take a step back. And when you look at the evolution of mixed health systems, you are only going to see that they're going to get more complex as time evolves. I think COVID-19 has showed the tremendous amount of partnerships that are happening across different areas of the health system that is really going to create new conflicts of interest as we go along. but also perhaps be able to resolve existing ones. I think, given these different presentations, a couple of points kind of come to mind. One is that in a mixed health system with multiple stakeholders, all stakeholders, and they include governments, agencies, commercial entities, health plans, digital providers, all of them have their own unique goals. And with these conflicts that go along with them when they build relationships with others. So any form of collaboration or partnership will also have in some ways an element of conflict associated with it. And I think there's a need to think about that. The second point is that conflicts need to be defined from the perspective of each party. And they need to be managed in a way that at the end of the day, it's the end user that is protected. And by doing so, we improve not only public health outcomes in the best possible way as possible. And the third is that transparency is essential, and transparency requires a mechanism to be able to disclose those conflicts. And so while economic relationships are important and easier to measure, the non-financial relationships also have to be better understood. So I think, unpacking conflict of interest is really a learning curve. We understand some of the traditional players and partners, but we're also going to have to understand some of these newer relationships. And third is that creative forms of collaborations can also break down silos between, say, traditional industry and non-industry partners. And this is where I'll probably lift off with two kind of thoughts going forward. One is, I think with COVID and my own interest, we're seeing an explosion of a third entity or the fourth estate in healthcare disruption, and that's digital providers. And you're going to have to deal with conflict of interest in this area as well. Governments are using, large-scale internet providers like Google Trends to track data. And it is estimated that over the next 10 years, you're going to have as many as 50 billion medical devices sending data to healthcare providers, patients, and each other. So the velocity, volume, and variety of data will also increase. And data flows from hundreds of patients in a control setting to thousands or more in a commercial environment is something that we are going to have to not only acknowledge, but also deal with. So I would say that as we are unpacking, conflicts of interest across several areas, at a policy space, at an individual space, and then at a larger, health system space, you also have to understand these different kind of actors. And my last point, I think, before I kind of conclude my comments is that I'll give you an example of where, there has been an attempt to resolve some conflicts of interest in a setting, in a low middle income setting, where there is not often the government oversight to regulate conflict of interest. See, you're dealing with countries where regulation is never the strong point to start with. So when you're dealing with that, how, you can self-regulate, you can have companies with deeper oversight within their mission and vision statements, or you can think of new partnerships where conflict of interest can be made more transparent. So for example, there is a partnership that I'm evaluating right now with a pharmaceutical company called Takeda. They're a Japanese pharmaceutical company, and they work extensively in many low middle income countries, and their range is actually rare diseases and NCDs. They kind of focus on this. So they had a very interesting partnership that they had in 2019. This is actually called the Blueprint for Success Initiative, and the partnership was actually called Innovative Health Care Access Partnership Model. What Takeda did was they actually partnered with 300 other non-state stakeholders, which across the board. They had pharmaceutical companies come in. They had, larger bodies like the NCD Alliance. They had, NGOs. And in 2019, they actually launched, and they used these to kind of develop, a series of healthcare interventions that really focused on improving the lives of patients with cancer and NCDs through early diagnosis and also local access to high quality treatment. This included screenings, public awareness, and so on and so forth. So one way they tried to manage this conflict of interest of Takeda being, say, a primary provider or donating medicines, or the private sector, coming in, was to use intermediaries. And so this particular pilot, which was in Kenya, at the Mount Meru County in Kenya, actually had an intermediary through which Takeda and many of these other private sector entities worked. And that was, so the primary entity was Amref Health Africa, who in turn brought in other alliances, like, for example, the International Cancer Institute, as well as the Kenya Medical Research Institute, which is the primary partner for this county. So the innovation of this partnership was to create a certain level of transparency in dealing with multiple stakeholders in a country where regulation was, not the strong point in the first place. So to me, conflict of interest is an evolving entity, and there can be different types of conflict of interest. There can be minor conflicts of interest. They can be major conflicts of interest. And it's really about balancing the two and knowing which one to balance first. So I'll stop over there, and over to you, Robert.
Perfect. Thank you very much, Priya. Extremely interesting. Again, you're reminding us of the complexity and how complicated this is, and how complicating this is getting. You reminded us also of the ongoing COVID-19 pandemic. I think that was the first mention of that today. I think it's obviously what you said, reminding us of the explosion of the fourth estate digital, 50 billion devices you mentioned, the velocity, the volume, fascinating. Really interesting points. Thank you, Priya. So we have now an open kind of panel discussion here. We'd like to talk about the types of conflicts of interest that are most pervasive and detrimental. We'd like to talk about solutions, what's possible, which actors need to be engaged, who can and should take responsibility given the political economy challenges around this, and we know and have heard again and again how profound and pervasive they are. But before we get into some of those broader questions, I want to come to your questions, and I'm seeing now we have a few in the chat, so thank you for your questions. I'd like to start with a question from Babatunde Balogun, who said, the picture painted of the drug shops in Uganda is not significantly different from what happens in many parts of Nigeria. Do we hold pharmaceutical companies partly liable, seeing that they tend to profit from the status quo? Could they be a key stakeholder in the health system's equation? So with that first question from Babatunde, I thought, Eleanor, Freddie, any thoughts from either of you to get things going here?
Can I throw this one over to Freddie? He is a pharmacist, and then I'll answer. I'll fill in after that. Freddie, is that okay? I put you on the spot.
Thank you, Eleanor, and thank you, Robert, for reading out the question. I very much agree with Babatunde. What we see in Uganda is replicated in many low and middle income countries and Nigeria as well. A lot has been written about it. So I think that yes, the pharmaceutical industry has probably one objective, which is to expand their market share. So any phenomenon, whether it's formal or informal, that helps them expand their market share, they're probably not opposite. That said, I think that they have a responsibility in ensuring that they maintain their market share without putting the public health and social objectives of ministries of health in jeopardy. So I think that in a number of countries, pharmaceutical companies are part of the high-level stakeholders in trying to create order. And I can give examples of the US and so on in terms of being strong on regulations and funding as some of the interventions to ensure regulations are actually met and setting the standard for R&D and so on. In our set, I think that a lot of pharmaceutical companies are not are external, are international. So we need to find a modality where we can involve them in supporting interventions within our countries, given that their stakeholders are external to our countries. With that, I think
Perfect.
I will let the other members add to the discussion.
Freddie, thank you. Eleanor, over to you.
I think it's a really interesting question. I think, so there are sort of two things in here. Yes, there are definitely similarities with Nigeria, but I think whenever you go into a medicines market, you have to think about where the people in that market sit in the political settlement. That gives you your scope for the sort of policy actions that are going to be taken up. You know, is this a market that's important politically or not important? Who are the people in the market? What are they selling? So I think there are all sorts of things to sort of pick apart in that. And I don't know where medicine sellers fit in the sort of Nigerian, within the Nigerian health system. Patent medical medicine sellers, I think there are. The pharmaceutical industry definitely is interesting, and there are absolutely conflicts of interest there. I think it's one of the things that is most difficult in terms of antibiotics is that, you know, you have a private sector company and we're asking them to, you know, curtail sales of particular antibiotics in order to protect them. You know, it's one of the sort of clashes in terms of the sort of drivers of sales. And has created, I think, all sorts of problems in the market. But we know that, you know, so for example, the lobby group of drug shop vendors, we know that there are pharmaceutical companies, importers in Uganda who are now trying to partner with the lobby group of the drug shop vendors who are becoming increasingly powerful. And this again is going to curtail the sort of technical interventions that you can put in place. And you know, what you always have to, like, just as they're looking for market space, we're looking for policy space. You know, where is the space, given the politics of these markets, given that they're so important for access as well, that we can actually make some improvements. And it may be a question at first of tinkering around the edges before you get a much more sort of substantial change in them.
Perfect. Thank you, Eleanor. We've got another question here now from Helen Schneider, who said, really enjoying the presentations, taking away bricolage of informal practices as a key idea. This raises many questions on how to approach local governance and shape practical norms when so many of the features are part of complex systems with multiple reinforcing loops. Related to this, we have a question from Sulakshana Nandi, who says, more and more we're seeing government setting up autonomous agencies to implement health programs. This opens up the space for the for-profit sector to be part of government decision-making and monitoring bodies. Therefore, a clear case of COI, which compromises the effectiveness. The National Health Authority in India, which is implementing the National Health Insurance and the Digital Health Mission is such an example. Could panelists comment on similar arrangements in their locations? Meenakshi, I was wondering if we could go to you, if you had any thoughts on these questions from Helen and Sulakshana. Meenakshi, can I put you on the spot?
Sure, with my pleasure.
Thank you.
Yes, I mean, there's so much going on that is complex, but I think, of course, the first step is to unpack this complexity. You know, as we do our analysis, we start by deconstructing and then trying to tease out the common denominators and issues that we can start working on in stages. So that's, you know, that's something that we have in mind. This is in response to Helen's question about where do you even start when you have so much complexity. So what we are planning to do is to really engage all of these different stakeholders who are part of the problem. We want to be able to work with them. I think Priya also talked about it. We're looking at multi-stakeholder engagements in co-designing interventions. And we're going to start in small steps, seeing what are the low-hanging fruits that we can work with. We'll be identifying the key relationships that underpin this bricolage of informalities. You know, there's so many win-win relationships that are in a way, they are the cause for these informalities. So we want to try and see how we can harness these relationships and try to transform the harm by trimming it, by converting it into something good. So an example could be that we try and develop guidelines for antibiotic use at different levels, but for that we need to we need to rationalize the regulation that all antibiotics can only be sold on a prescription. Clearly they can't, because we don't have so many prescribers. So let's start by seeing which ones can be used more openly. Some of the access ones perhaps can. So that's what we want to do. Then Sulakshana talked about, can you just remind me about Sulakshana's question? What was that? It was about the role of the government.
Yes.
Right?
Sorry,
in these systems.
Yeah. Yes.
So that is again really complex, because these we are talking about systems where governance is overall weak. If we had strong governance, we wouldn't have this kind of a situation. So the government is limited in its own capacity to be able to provide stewardship to this kind of a mixed system. And I personally, feel that, yes, there is a lot of desire to have a perfect public health system in these countries. But how realistic is that? And is that kind of an aspiration not preventing us from trying to harness the existing reality, this global reality of the health system, that where there are so many different kinds of providers, there are so many relationships? Why are we not trying to engage with all of them, harness the situation, and use that for universalizing health coverage, rather than looking at a utopic situation, which perhaps will never happen, where every village will have access to a qualified doctor or a physician or a surgeon? That's not going to happen. So perhaps for governance of these systems also, we need more collaborative platforms that can somehow negotiate, work around their own conflicts of interest. We need more responsible players coming in from all fields and joining hands with the government. And I think we as researchers also have a very strong role in that, in trying to promote that kind of a shift in thinking and action.
Perfect. Thank you very much for that very thoughtful and reflective response, Meenakshi. It's now 13 after the hour. I realize we're running out of time. We still have a few more questions, and I'd like to come back to both Priya and Mishal. And so I'm going to go now to a question from George Gazatse, who's said, looking at the Uganda drug shops, would solutions be technology and systems focused? So example, he gives some examples here about using technology, using digital web-based management tools to manage systems better. Priya, I wonder, given your comments, if I could ask you about that, if you might be able to reflect on the possibilities for technology and digital solutions to some of these challenges. Priya?
Yeah, sure. So do you want me to go first?
Yes.
So technologies to kind of answer some of the conflict of interest challenges.
Yes.
Yeah, I think the technology can also, in some ways it can be a little bit of a double-edged sword. Let's talk about the positives of technology first. I think technology can resolve some of this because technology can encourage transparency. So for example, let me give you an example. So, in India, you have a center called the Center for Cellular and Molecular Platform. It's called CCAM, and it's an incubation and innovation center. And they basically are co-funded by the government of India. And they also have a number, they use their, their aegis to essentially, promote innovation in health and different kinds of innovation. So interestingly, one of the innovations that they promoted, comes back to what Meenakshi and Mishal are all talking about, AMR. So they have prototyped a company called Bugworks. And Bugworks is essentially a private company that is developing a broad spectrum antibiotic to deal with a lot of the gram-negative bacteria which are currently AMR resistant. So, your E. coli, Pseudomonas, Klebsiella, and so on and so forth. But it's very interesting. So the way that they have structured this partnership was that what CCAMP essentially allows is a pooling of financial resources. It allows pooling of intellectual property and ideas so that you can actually work together to solve even some of the regulatory and conflict of interest problems together. And in terms of who owns the data, since the government is an active investor in this, the government also ends up having a large chunk of being able to regulate the data that comes out of something like this. So I think there are, I think digital technology can offer very interesting and innovative solutions. It can also lead to very interesting collaborative partnerships. So I'd like to, reprise what Meenakshi said, that at the end of the day, you cannot think of an utopian system where magically politicians are going to, present themselves as angels, where, they'll say, from today, I will make sure that I'm not on the board of any private hospital. A lot of politicians and MPs at the end of the day are businessmen. They come into politics to further their own interests. But having said that, you can use technology to create a certain level of transparency in the systems that you create. So my thing is, rather than penalizing drug shops, they should be partnerships with them. Rather than penalizing the informal structure, we should have partnerships with them. And technology can help bridge some of those partnerships.
Perfect. Thank you very much for those comments, Priya. Again, the importance of digital to increase transparency, to facilitate partnerships, to advance on these issues. Thank you. I'd like now to go to Mishal for what I think will probably be our final question here. And this is again from Helene Schneider. She says, in any of the case studies, were there opportunities or nodes identified for introducing public interest conversations amongst actors? Mishal, I was hoping we could come to you for this question, and then any final ideas or conclusions from you before we end the session. Over to you, Mishal.
Yeah, sure, thank you. Yeah, absolutely. I think both, there's this idea that when we're introducing or thinking of introducing stronger regulations, that there has to be support for them, right? And when there's already conflicts of interest, so I'll put this in a specific example of regulation of medical education, and going back to an earlier question of the regulators themselves having private medical colleges on the boards, because I'm using the example of Pakistan, the number of private medical colleges greatly outnumbers the number of public medical colleges. So it was understood that therefore there needs to be a strong voice of private medical colleges on those boards. Now, if you can see how that'll create a conflict with stronger regulations on, say, the quality or the tuition fees of such medical colleges. But then there's also, if there's opposition from doctors themselves to stronger regulations and the general public, because they might be afraid of having fewer doctors, then it becomes really, really impossible, because the regulators not really wanting to do it because the regulators themselves own these, and there's the public doesn't support. The people who are trying to regulate are saying, we don't want a national licensing exam. We're quite happy not having one. it just makes our lives easier. And that's the situation in Pakistan, that you can graduate from a medical school without having a national licensing exam. So one of the solutions must therefore be based in getting the public and the people who are being regulated themselves, when they're doctors and they make up a huge body, to actually be, even if we can't get them to supporting the regulation, so I agree we can't be too utopian, but to shift them slightly away from being huge opponents, or at least seeing the benefits and having some quality control over, say, medical education, whereas right now perhaps even some of those dangers or concepts are missing. So yes, I think it's really an essential first step to be able to bring in stronger measures. Thank you.
Thank you, Mishal. Thank you to all of our panelists. So thank you again, Mishal. Thank you, Meenakshi. Thank you, Eleanor. Thank you, Freddie. Thank you, Priya. And thank you to our attendees and our participants. I think this was a very lively discussion. I'm sorry that we've run a little bit over and we've now run out of time. We haven't been able to address all of the questions, but I think with your participation, with the questions, we've had a very active discussion. I think given this topic, I'm sure this will not be the last word, but I think this is really the beginning of a critical conversation, an important conversation on conflicts of interests in health systems and LMICs. And I think after this session, we'll be able to have opportunities to continue this conversation. So thank you again to everyone. Look forward to being and staying in touch. This now concludes this session.
Thank you.
Thanks very much.
Thank you. Thank you, and bye for now.
Thanks, Rob. Thank you.